Okay, welcome everyone. My name is Tristan Claridge and I'm the convener of this webinar series for the International Social Capital Association. The association's mission is to advance the research and application of the social capital concept, and if you're interested in membership, you can check out information on our website. In this session, we welcome Mara for a presentation titled Healthcare Network Governance and Accountability Shaped by Social Capital. Mara has a strong research background and almost a decade of industry experience as a senior economist in a public teaching hospital, business manager and main inspector at the National Agency for Fiscal Administration. She completed her PhD at the University of Galway in Ireland, and currently Mara holds a position of lecturer in operations and supply chain management at Atlantic Technological University in Ireland, and program coordinator of the Master of Science in Supply Chain Analytics and Healthcare Innovation and Technology programs. Mara's research examines governance structures and operations management in mandated hospital networks and has a strong focus on social capital theory and its application in networks and supply chains. We're delighted that you've agreed to give this webinar. Welcome, Mara, and over to you for the presentation.
Thank you so much, Tristan. Thank you so much for the warm introduction. I think you covered everything. There's not really much to add there, just that I'm very excited to be here tonight. And this piece of work actually is a part of my PhD. The study was very complex, as you will see as I go through the presentation, but of course, due to the limited time available, I'm just going to focus on the network governance as part of this seminar, and maybe, who knows, the second part will come in a second seminar afterwards. So this particular paper focuses on the network governance structures and accountability shaped by social capital. So what we wanted to do here, we tried to check or to kind of understand how the network governance, how network governance structures are implemented in a hospital network. And I will move to my presentation now. Hopefully all works well, and I will just walk you through it. So for this particular paper, I worked with my colleagues, Geraldine Robbins and Breda Sweeney. They are both at the University of Galway. So just a little bit of a background. I'm not sure to what extent are you familiar with public sector research, but to kind of give you an overview and a little bit of a background in terms of how we ended up having these networks, public sector networks. So all of this was kind of influenced by two main research reforms called New Public Management and Post-New Public Management. Not sure if you are familiar with them or if you've heard of it. If you please feel free to jump in at any time during the presentation if you have any questions, but I am going to try to give you a brief overview of all the aspects that are required to understand, let's say, the study that we've conducted here. So these two major reform trends conducted or led to significant transformations in the public sector. The first reform trend was the new public management reforms, and this was a set of ideas that emerged sometimes in the 80s and proposed the introduction of performance measurement in the public sector, increased transparency and more accountability for results, and also it was proposed a more vertical coordination. So while all of this was very interesting at the time, extensive research conducted in this space usually led to the conclusion that, or reached the conclusion that new public management has often failed to achieve its objectives. And it was often characterized as being a disappointment for the public sector. And in response to this criticism, we have a second reform trend called the post-new public management reforms, which predominantly focused on horizontal coordination. They proposed pooled budget and standardization across across public sector institutions. They proposed a stronger centralized control and joint targets and shared goals for public sector organizations. So as we can see, the post-new public management reforms were more focused on lateral integration and proposed the formation of these public sector networks, which are also called, in the literature you might find them as mandated networks. So these mandated networks are collaborative arrangements established through government mandates to achieve collaborative outcomes. So these mandated networks, they do have some particular characteristics in the sense that they are initiated by policymakers. And these policymakers then regulate members, constituent member organizations. They regulate what are the tasks. They set up the objectives of these networks. They establish what are the formal rules and procedures within these networks, and what are the decision-making structures. And all of this is conducted in the expectation that by mandating this collaboration among public sector institutions, this will eventually lead or facilitate increased performance of public sector institutions due to a more efficient use of resources, and it will generate more sense of competition between public sector institutions. And this was mainly because when we collaborate and we work together, one aspect that happened is that it's this increased visibility of organizations' activity. So then when organizations are involved in these collaborative arrangements, no one organization wants to be at the bottom. So this was the idea behind these reforms, that it will stimulate some competition, which will lead to greater use of resources. It will facilitate learning by working together. It will facilitate, or it will increase capacity and responsiveness to critical situations. And eventually it will improve the quality of services delivered by working together and finding new ways or more innovative ways of delivering services. Now, all of this sounds great, but as in any thing that, you know, it's implemented in every aspect of the world, there are benefits, but then, of course, there are challenges. And mandated networks are not an exception from that. There are significant challenges identified by the literature when it comes to these mandated networks. And some of these challenges refer to the inability of organizations to choose their partners. So basically, we have all of these public sector institutions who end up being in these imposed partnerships. And we can have organizations coming to work together, but they lack common interests. There might be culture clash between organizations, because we might have organizations in different parts, in different regions of the country. There might be different mentality in that part of the country. There are differences in size and unbalanced influence of certain members. As in any collaborative context, certain members might tend to dominate the partnership. There's also challenges for accountability, as because of having these multiple organizations working together, it can become at times diffused, and it might get lost in the governance structures. So these are important aspects to have in mind when we talk about mandated networks. And also, the literature often states that because of these challenges, it often happens that mandated networks fail to achieve their intended goals. But one way to try and increase the ability of these mandated networks to achieve their goals is by setting up effective governance structures. And in terms of governance structures, there is this paper by Provan and Kennis. They conducted extensive research in this space of network governance. And actually, they defined governance as the use of institutions and structures of authority and collaboration to allocate resources and to coordinate and control joint actions across the network as a whole. And in their research on network governance structure, they actually identify or they distinguish 3 types of governance models that can be found at network level. So one of these type of network governance is shared governance, which is generally characterized by having all network members equally involved in the governance of the network. And all network members have equal decision-making power for strategic and operational aspects or matters. Then in the middle, we have the network administrative organization, which is a more hierarchical, let's say, type of network governance, which consists of one organization which is responsible for the decision-making process and for the coordination of the network. But an important aspect is that the NAO is not a network member, but is rather a separate management or administrative body set up specifically for the purpose of coordinating the network. And then the third type of network governance is the lead organization governance, which usually occurs when we have one bigger organization in a network which assumes the role of network coordinator. But this organization, unlike the NAO, it is a network member. So because we talk about governance and because we talk about multiple organizations working together, it is very important to understand that effective network governance requires building relationships. And here we have a quick snapshot of the different types of network governance. As we can see, they create a continuum that ranges from hierarchical to hierarchical models. We have the shared governance, which is usually more decentralized type of network governance, with all network members being involved in the network governance. And one benefit, like the strength of this type of governance, is that all network members are equally involved in governance. But a weakness is that it can become messy and sometimes inefficient. It might be difficult for members to reach agreements. Then we have, in the middle, we have the NAO, which is it's a centralized and brokered type of network governance. As I was saying, representation of the network is done by the NAO. In terms of strength, is sustainability and the legitimacy of the NAO, but it can be at times inefficient because the decision-making process can become bureaucratic at times. And then finally, we have the most hierarchical type of network governance, which is the lead organization. The strength of this type of network governance is its efficiency and legitimacy, but the downside is that it can take a dominant role in the network and is the potential for opportunistic behavior by the lead organization. So having this in mind, while network governance has been extensively researched in the literature, there are still calls in the literature for further studies looking at, how the network governance, and in particular how network governance evolves over time and how it changes over time. And this was the motivation that led us to this study, and we wanted to understand more about this network evolution. So the research objective was to understand how network governance is implemented in a mandated hospital network. Again, as a reminder, mandated network was formed as a result of reform implementation in the public sector. So what does all have to do with social capital? Because this is the point, this is the whole purpose of the presentation. So in terms of social capital, we identify this theoretical lens as being the most suitable for understanding the relationships that were developed in this network, hospital networks. And particularly because social capital is one of the 4 types of capitals which provide organizations with advantages. And the core idea of social capital is that those who do better do so because of their relationships, and individuals or groups or organizations are able to achieve outcomes that could not be otherwise achieved by only working individually. And this view of social capital overlaps with the objectives of the post-new public management reforms, which also promoted collaboration or saw collaboration between public sector institutions as a means of achieving greater performance, better use of resources, increased efficiency, and so on. So this was actually, in fact, it was the post-new public management slogan was working together. And there's also acknowledgement in the literature that the whole purpose of creating these mandated networks is to leverage the benefits of social capital that can be derived from having these multiple organizations working together. Now, in terms of the social capital conceptualization, we follow the Adler and Kwon paper 2002, and we looked at this, we identified the 2 dimensions as in bounding social capital, which is concerned with this quality of relationships, and it's characterized by norms of reciprocity, solidarity, and shared values. And also we know that bounding social capital usually forms within collectivities, and usually it's developed between individuals who share similar characteristics, such as, you know, race, family, and so on, common friends, and so on. However, one potential, let's say, negative aspect of the bounding social capital is that it can tend to be exclusive towards outsiders. And then the second dimension is the bridging social capital, which is concerned with the quantity of relationships and the diversity of relationships. And this type of social capital provides access to information, exposure to novel ideas, and so on. And here we have the Mark Granovetter's paper on the strength of weak tie, which I think explains very well the potential benefits of bridging social capital. But also social capital, in addition to these 2 dimensions or views, it can also be seen as public or a private good, depending on who benefits from, you know, the social capital or the advantages generated by social capital. So in terms of social capital as a public good, this is usually, you know, the benefits of social capital are available to a community, to the entire community or network. In this case, available to all network members. And this view of social capital as a public good aligns with the intentions of the reform implementation in public sector. In contrast, social capital as a private good is an asset that individuals can use to benefit their own situation. They can use it for their own advancement. And how would this translate in a network context is that it would be one network organization would use the social capital to benefit for its own benefit rather than the benefit of the network overall. And this social capital is a private good can form or derives from the tendency of people to build in-group solidarity at the expense of outsiders. However, going back to our network governance structure and how we can overcome these different challenges that we might face in terms of the different types of social capital that might form, the literature notes that the NAO governance model, because we have this individual, separate, impartial administrative body responsible for managing the network overall, this type of governance would be most suitable in counteracting the potential of social capital to form as a private good and to benefit just one network member. And that is because being separate, this NAO model can act as a centralizing force and can prevent the formation of these subclusters or these strong subgroups within the network. So having all these theoretical aspects in mind, in terms of the research context, we conducted this study in the Irish healthcare system. Just a quick view of it. It's predominantly tax-funded, and it combines both public and private healthcare services. But one important thing that happened in Ireland in 2013, the government proposed the reorganization of acute hospitals into more efficient hospital groups. So basically, all hospitals in Ireland, which initially were managed independently and autonomously by hospital managers, were all of a sudden brought together as a result of this reform implementation, and they were expected to work together. By creating these hospital networks, the reform hoped that this will reduce fragmentation of service delivery. It will increase access to and quality of care. And if any of you is familiar with the Irish healthcare system, one significant problem is the very long waiting lists. So this, reform hoped that it will address, or was seen as a potential solution to dealing with the long waiting lists and improving quality of care, and also standardization of clinical practice. So as a result of this reform implementation, we have now 7 hospital groups in Ireland, and we conducted this study in one of these hospital groups, which I will call it Blue Care Hospital Group from now on. And this group consists of 5 public hospitals. Hospital 1 is the hub hospital or the tertiary care unit of the group, and then we have 4 smaller hospitals. In terms of the research methodology, we adopted a qualitative research approach, and we conducted 55 semi-structured interviews at very senior level within the organization. We had very good access to individuals in this network. We conducted 9 interviews at network level, and 28 with senior doctors, 12 with nurses, 4 with general managers, hospital general managers, and 2 with finance managers. We also reviewed an extensive amount of secondary data, and all this process of data collection started in 2017 in December, and we finally finished in 2020. And in all this time, we visited each of these hospitals multiple times. So with that being said, because our aim was to look at network governance structure, the first thing that we did was to examine the reform initiative, the reform text, and to see what type of governance structure was proposed or was intended to be implemented in these newly formed hospital groups. And the reform text proposed provided detailed information about how the network governance should be implemented in these hospital groups, or how these groups should be managed going forward. And one thing that was highlighted in the reform was that the reform, that each hospital network was allowed to have its own governance structures and management structures. And going and analyzing the requirements or the recommendations of the reform, we identified quite quickly that the proposed model was actually consistent with the NAO characteristics explained by Provan and Canis in their own paper. So we identified the proposed governance structures and an NAO comprising of a board of director and executive management team. The responsibility for the management of each hospital group was assigned to the executive management team, and in particular the chief executive officer, who was invested with the responsibility of allocating funding across the network as well to each individual hospital. One important thing that was mentioned in the reform text is that they proposed the formation of this network executive team, and they proposed 6 key leadership roles to be to compose or to form this executive management team at network level. And this executive management team was responsible for all the major decisions of the group in setting the network strategy and addressing network operational challenges. Another important aspect that was highlighted in the reform text was that the leadership of the group is not the same as the leadership of the largest hospital in the group. And there was a requirement that there needs to be a clear differentiation between the 2 roles. So this is basically what was intended. And yes, Hospital 1, according to the mandate, each hospital group was to have a tertiary care unit assigned to the group in order to be able to provide support to smaller hospitals in terms of dealing with more complicated cases, clinical cases. So this was basically what a snapshot of what the governance structures were intended through this reform. So now, just to give you an overview of maybe a visual overview. So the NAO consists of the board of director and these 6 key leadership roles that were responsible for all important decisions in the network. One important aspect to mention is that a significant change for these hospitals in the network was that before the implementation of the reform, the health service executive, which is the authority in Ireland responsible for the management and delivery of clinical services, the health service executive, prior to the formation of the network, would allocate budgets directly to each individual hospital. After the formation of the network, budget was allocated as a pooled budget to the NAO, with the group chief executive officer being responsible to decide how to allocate, or like the level of budget allocated to each individual hospital based on their size, geographical location, and so on. So then, going from what was intended now to looking at what actually happened in practice. So when we started conducting these interviews and meeting with people, it became very clear. It became clear from the early stages of the interviews that there was the findings revealed the emergence of this lead organizational model at governance of the governance at the embedding stage. So from early stages of network implementation, there was a lead organization model emerging in addition to the NAO model, which was expected to be implemented and was recommended by the reform. And why did this happen? It was because the reform did not provide very clear specification how those 6 key roles should be selected, or how a recruitment should be conducted. And most of them were through expression of interest from people working in the healthcare services. And most of this position, 5 to be exact, 5 out of 6 of these key network executive roles were taken up by individuals who, before joining this reform, joining this network, they held leadership roles for many years at Hospital 1. So most of these people worked together for over 20 years by the time this reform was implemented. And basically what happened was the finance manager of the hospital, H1, became the CFO of the network. The clinical director of H1 became the clinical director of the network. Another thing that was interesting to see was that the network executive members, the executive management team members, were all collocated at Hospital 1, on the site of Hospital 1, where they were working previously. So basically there was no change here, and there was no clear separation of roles, even though the reform strictly specified that. Then we had board meetings organized a few times a year, and these were intended to rotate across the network to give the opportunity of network members and to meet the executive management team. However, for efficiency reasons, it was decided that most of these meetings would be held at Hospital 1, which actually happened. And this limited the opportunities of staff from the other hospitals, smaller hospitals, to attend these meetings because there is significant geographical distances between these hospitals. The governance, these governance arrangements where we have these powerful positions being taken on by prior leaders at Hospital 1, combined with the fact that this network executive team was physically co-located at Hospital 1, this created a context which gave H1 the opportunity to adopt a dominant role in the network. And this influence of Hospital 1 in time led to securing greater resources for their hospital. There was significant criticism by staff in the peripheral hospitals that Hospital 1, because of this co-location of the executive management team, where they are prioritized in terms of resource allocations across the network. And also came to influence the outcome of clinical service development initiatives. And as explained by one manager in one of the smaller hospitals, like if they wanted to develop a new service in their smaller hospital, this decision would be strongly influenced by clinical staff, like doctors at Hospital 1, and they would advise the executive management team whether or not that would be a wise idea. And more often than not, it doesn't go through, it doesn't go forward, because they always identify issues and advise not to go forward with the project. So the overall sense of peripheral hospitals was that they became a spoke in this arrangement, and that they weren't a spoke before. In terms of accountability over resource allocations, there were new clinical roles were developed and were created both at hospital and at network level. And these clinical roles promised that budgetary responsibility will be assigned to these clinical roles. So doctors who engaged in these roles hoped that they would have responsibility over budget, and they would be actually able to drive innovation and change within their service. However, this didn't materialize, and the same practice that was used before the formation of the network, where the budgetary responsibility was managed, rested with the general manager, that practice still remained even after the formation of the network and even after the creation of these new roles. These clinical roles then became weakened. They were perceived only as a fancy title that did not give any opportunities to make any change. These doctors who engaged in or took up these roles, they found themselves having increased workload and accountability, but with no opportunity to make any change within the service. And they were actually expected to manage a service without having budgetary responsibility for the service. And that created, of course, a lot of frustration across the network amongst clinical staff. It also impeded the ability of these clinicians to build relationships across the network, because all these clinicians took up these roles, these managerial roles, in addition to their clinical role, their clinical and teaching commitments. And these clinical roles were only 4 hours a week was allocated as protected time for the managerial tasks, but that was not enough, and therefore most of these clinicians did not manage to engage properly with the role and did not manage to build relationships with their peers outside of the network. And as a result, that led to a complete lack of interest by hospital doctors to engage in these roles, and they mainly ended up having an arrangement like, I'm doing it this year and you're going to do it next year, and that's it, really. So another aspect that was noted by participants was that after the formation of the network, the decision-making process regarding resource allocations became highly bureaucratic and slow. It became very difficult to recruit staff after the formation of the network, because before the formation of the network, when the budget was managed and decisions in terms of recruitment were made locally at hospital level by the general manager, the process was much faster. Whereas after the formation of the network, this decision for employing somebody had to go through, or had to be approved by the NAO executive management team. And again, as I was saying earlier, according to participants, more often than not, these decisions would be, let's say, rejected for peripheral hospitals, and they were prioritizing the allocation of these resources and recruitment in Hospital 1. So then those were pretty much the findings. And what we actually found here was the emergence of this lead organization, or the coexistence, better said, of this emergent lead organization and an espoused NAO, which coexisted. And why was this possible, and why we ended up having this governance structure? That was because of the strong bonding social capital between Hospital 1 and the executive management team. These strong bonds, as I was saying, were long developed before the formation of the network, and then they continued to be facilitated and strengthened because of the physical co-location of the executive management team at Hospital 1. And what we saw, it was interesting to see that these two types of network governance were used for different purposes. The NAO, which was the intended network governance model, and of course, as a result, had external legitimacy, was predominantly used in relation with funders and government agencies. But the lead organization was utilized for clinical service development and decision-making process. It was used internally predominantly, and this became much more obvious when we examine the operation side of the network, but I'm not going to talk about it now. This is just about the network governance. But yes, the influence over clinical service development became significant in this network. So as a result, these strong bonds between Hospital 1 and the NAO hindered the development of bridging and bonding social capital across the network, and peripheral hospitals often felt excluded from the decision-making process. And social capital was perceived to become a new power of Hospital 1 that significantly influenced governance arrangements in this hospital network. What were the implications for the NAO, giving this context? its ability to operate as an independent and neutral and impartial administrative body was challenged by this structural arrangement. And as a result, it failed to integrate hospitals in the network. And while the literature argues that the NAO model has the potential to prevent from the formation of these subclusters within the network, in this case, it was interesting to see that the NAO itself became one of these exclusive groups, or became part of one of these clusters. We saw problems of asymmetrical power and dominance of one network member, in this case H1, in terms of resource allocation, service development initiatives. And another thing that kind of draw our attention was that because of this co-location of the executive management team at Hospital 1, the accountability lines became very blurred. It was very difficult for staff in the peripheral hospitals to distinguish between these two entities, Hospital 1 as a network member and the NAO as an administrative organization. And they were often seen as being the same. So it wasn't clear for staff in the peripheral hospitals who's managing this network. Is it the NAO with the influence of the Hospital 1, or was it Hospital 1 with the influence of NAO? But overall, they were seen as being the same and managing the network together. And this significantly weakened the internal legitimacy of the NAO, where it wasn't clear for any staff which is exactly the governing body of this network. So these staff in the peripheral hospitals perceived the strong relationship that were developed between H1 and NAO as a private good that was leveraged by Hospital 1 to benefit its own situation. That was obvious for them in terms of resource allocation, where I think 90% of staff in the peripheral hospitals agreed that Hospital 1 was prioritized and supported by the executive management team when it came to resource allocation, where they didn't feel the same support when it came to their own hospitals. Other aspects such as staff constraints and resource allocation across the network impeded the ability of these staff in the peripheral hospitals to engage in network level activities. Clinical staff in the peripheral hospitals often found themselves working overtime in order to deliver the services, which significantly led to their attrition, their inability to engage in any other initiatives. They were just working to deliver the service and keep the hospital running, basically. There was a strong, as I was saying, sense that Hospital 1 was prioritized in terms of resource allocation, and this was contrary to the reform recommendation, which clearly specified that allocation of resources within the network has to be done in an equitable way and to avoid over-concentration of resources in the tertiary centers. But findings from the studies say that this wasn't really the case. So as a result, there was an overall agreement, just as a conclusion of this case. The overall agreement among interviewees was that collaboration in this network was very, very limited. There was no, sharing or to a very limited extent. Now, in terms of the contributions, we make two contributions. One focuses on the network governance literature, and particularly we focused on Provan and Kenny's argument. In their paper on network governance, they acknowledge that network governance can evolve over time, but they say that this evolution typically occurs from a decentralized shared governance model to a centralized NAO or lead organization governance model. They also argue that once the NAO is adopted, an evolution to another governance models is unlikely. So in this case, we kind of extend this view on network governance, and we demonstrate that that evolution of network NAO can happen if there is a adequate context to facilitate that. And in this case, we saw that this coexistence of these two types of network governance models happened because of the strong social capital between the two, between NAO and Hospital One. So this was an interesting thing to find, to see these two hierarchical and centralized governance models coexisting in one network. And this is different from what I found in the literature, where usually network governance or these kind of hybrid models of network governance usually combine a decentralized model with the centralized model, just to give participants that sense of being part of the network and to ensure inclusions of network members. But in this case, we saw these two hierarchical networks models, which was interesting to see. And finally, in terms of the social capital area, we focused more on the dark side of social capital, and we showed the ability of social capital to fragment collectivities such as networks in the name of more local identities. We also demonstrated the potential for exclusion and dominance. Usually the social capital literature focuses more on the positive side, but this dark side, we cannot ignore the dark side, and perhaps more research is welcomed in this space as well, to have a better understanding of what are the negatives of social capital as well. And in terms of implication, we highlighted the need to monitor social capital development during network governance implementation, and policymakers should pay significant attention in terms of where the NAO is located, and to provide more directions in terms of the composition of the NAO. Because as we saw in the study, if there is no physical separation between the NAO and network members, we can have these strong bonds, which will then skew the network governance on one side. And also it is important to try and create an executive management team that is impartial and that has consists of members from perhaps all hospitals in the network. Now, I need to mention that before I finish, that the network structure looked for expression of interest for these 6 key managerial positions from the peripheral hospitals as well. But unfortunately, because the executive team was based at Hospital One, it was very difficult for staff in the peripheral hospitals to express interest in this position, because that would have meant for them to relocate to a different city where Hospital One was based. And that also facilitated this kind of dominance of prior H1 leaders in the executive management team. Yeah, so that was it. I think I am in time. Yes.
Thanks very much for your presentation, Mara. Fascinating research that you're doing.
You.
And I can't imagine how much data you had. 55 interviews. It sounds like an enormous amount of data you would have had to analyze for this research.
Oh yeah, and this is just one part of it. This is just one part of it. We have another part coming out where we focus on the operation side, and we look more at the control systems that were developed. And then there we see more clearly the influence of Hospital One in the development of control systems in the network as well.
Yeah, very interesting. So we'll take some questions and discussion. So feel free to raise your hand if you would like to ask a question. You'll see a hand symbol within Google Meet, just down in the bottom bar. Alternatively, you could post in the chat if you'd like me to read the question out on your behalf. I'd be happy to do that if you're not in a position to ask the question yourself. There was one question in the chat from Lanive Julian. The question, I think, was asked while you were talking about your methodology, but it's not exactly clear exactly what the question is. So, Lanive, if you're still here, feel free to unmute yourself to clarify your question. The question is about undermining impartiality or neutrality or fairness.
Yeah, no, I think it makes sense. So because why was the impartiality of the NAO affected because of this arrangement? It was because, as I was saying earlier, all these network managerial roles were taken by previous leaders at Hospital One. So they already had very strong relationships between them. And we already know that frequent interactions, also facilitated by the co-location or proximity, has the potential to strengthen these relationships and lead to strong personal bonds. So then there is the tendency, and there is research as well, where social capital can be used to obtain support from network management. And that's what it influenced, because they are the executive management team loyalty, let's say, well, it might be too much to say that, but anyway, they were more tended to support their own hospital because they had prior relationships and they worked within the hospital and they knew that hospital way more than they knew a hospital that was 200 kilometers away and they had very limited relationships with. So I think that would be an answer to the question.
And it sounds like overall the network wasn't working very effectively. It seems like there was a lot of that kind of preferential treatment and the establishment of networks and perceptions of inequality, like you were saying, because H1 ended up becoming such a dominant part of the network. And that seems like it really undermined the ability of the strength of the social capital across the network.
Yes, it did. Well, it did across the network, yes. It was formed to a very limited extent. Maybe we had some evidence of bridges across the network, and those were more among nurse managers, really. Among doctor, not so much, not at all, really, because these network managerial roles for the doctors, they were supposed to, they had, or part of it was collaboration across organizational boundary. But because they took on these roles, in addition to their clinical commitments and with very limited protected time, they didn't have time to engage with those roles. And then again, even additional network managerial meetings that were organized in the network as an attempt to bring together staff from different hospitals were also arranged or hosted at Hospital One predominantly, which again created difficulties for people in the peripheral hospitals to travel. And then they were also scheduled more so in alignment with the schedule of doctors at Hospital One, without really taking into consideration the clinical commitment of the staff in the peripheral hospitals. So then you would have situation when you had meetings, but then a lot of doctors, they had clinics. So they had to choose, do I close my clinic, cancel my clinic and leave the patients to go to the meeting, or I don't go to the meeting and I stay with the patients, but then I cannot contribute and I cannot represent my hospital into this meeting. Yeah.
Yeah, I was wondering, there is actually a question in the chat we'll come to in just a moment, but I was wondering, from a big picture point of view, how do you think the concept of social capital, using the concept of social capital in your research, how do you think that helped to illuminate the research context? Like, what lessons do you think you found from using social capital as a concept that you may not have found otherwise?
Yeah, I think it helped me understand what was going on in this network, really, because everything that happened after, now I understand that I have a much broader view, because as I was saying, there is another paper that I'm working on a different part of the same context, but a different part. But that helped me understand how Hospital One managed to get that strong dominance and influence within the network, which wasn't clear before. And as I was talking to participants, that was coming out fairly often, the dominance of Hospital One. But it was interesting to see how it led to there. And then little by little, going and investigating and conducting a lot of research, I managed to find who, how long these executive management team members worked in the hospital before, who worked with who before the formation of the network. And that gave me the picture. And then it became very clear, really, that there was a strong sense across the network of the uneven or unequitable resource allocation across the network, and favoritism of Hospital One. Yeah.
Yeah, so it sounds like, from a lot of the work that I do, it sounds like perhaps what was missing was a sense of collective solidarity across the network, or perhaps a strong sense of shared goals or purpose across the network, where everyone was working towards the same mission, the same goals of making the entire network effective. And in the end, with a lack of that, it sounded like there was a bit more individual relationships and preferential treatment based on who you knew and who you had those relationships with. Is that your perception of what was going on?
Yes, it was. And it's also because all of these hospitals, they were used to working together. They were used to working independently before the formation of the network. So all of a sudden, they have changed from, having their own structures, their own rules, their own way of doing things, to all of a sudden having to report to some, network administration that we don't know, that we haven't worked with. And that created a lot of stress from the beginning. And it was kind of uncomfortable for hospitals to join the partnership, especially because they weren't really asked if they wanted to join. It was a mandated collaboration. They were assigned to a group, and off you go, make it work. So that was pretty much the reasoning behind it. So yeah, I do think that it's a pity that it didn't really work. And I think another aspect that was, because you might think that these hospital networks are created with this, hub and spoke model of care in mind. So you would expect to have a larger organization. But the problem in this case was that while Hospital One was assigned as a tertiary care unit, and in theory was supposed to provide clinical support to smaller hospitals, it failed to do so because there was no investment in expanding the capacity of Hospital One. And Hospital One was already struggling with long waiting lists before having another 4 hospitals to take patients from. So from that point of view, I think that created a significant friction there, especially between doctors, because they had doctors from the peripheral hospitals had no ability to refer their patients within the network. They continue to rely on their personal relationships developed with hospitals outside of the network. But then you have these big hospitals coming and giving you directions in terms of what you do. And then you also have this perception that budget is, or like this hospital is prioritized from a budgetary perspective as well, and resource allocation. So then, of course, it became very difficult. There were very tensioned relationships within the network. There was also perceived differences in the parity of esteem between clinicians at Hospital One, being a tertiary care unit, and those in the smaller hospitals, which again, contributed to increased frustration and limited interest by doctors in particular to engage in any network level initiatives. And actually, somebody actually said that for the first few good years, they were only a group in name only, without any, so just, on a paper really, but they weren't working. Now, of course, this study was conducted we completed data collection in 2020, so it might have been, improvements from a collaborative point of view, but this is what we found out at that time. And even at the time, it was significant because the reform was implemented in 2013, and we completed data collection in 2020. So 7 years, and it was still found these issues. So I don't know to what extent it has improved ever since.
Yeah, I mean, it sounds like if they had taken social capital into account when they did the reform, then things may be quite a bit different. Because it seems like, from memory, Adler and Kwong, when they talked about social capital, they focused on the opportunity, which I guess is the network creates the opportunity. And they talked about, I think they used the term motivation for engaging in that type of social action. And they also talked about the ability, which I think they really talked about the ability to realize the benefits of social capital, sharing of information, resources, and so forth. And so the opportunity was there because the network was created. But the motivation seemed like it was altogether lacking, because it doesn't sound like there was a lot of purposeful attempt to shape that motivation when they did the reform. People were sort of thrown into this network and they hoped that it would work out, and it doesn't sound like it particularly did.
It's true. There were a lot of things that should have been taken into consideration before the implementation of the reform, and a lot of it should have been clarified in the reform text, because there were some flexibilities there, as I said, which kind of allowed for a more flexible allocation of these key roles across the network. But another aspect that I had in mind was, you were saying about opportunity, motivation, and ability. We actually look at through this lens in this second paper, where we look at the operational side, because there we have a very interesting context where we have how clinical guidelines are developed, and again, what opportunities have these staff in the peripheral hospitals to contribute to that. We have network managerial meetings, we have patient referrals. So we look at various types of links that were developed or could have been developed in the network, and whether or not they were developed, and what hindered that. And basically, this is one of the main thing. It's the the motivation, I won't say 100%, because in terms of motivation, we found that the key motivator for everybody in the network was the best interest of the patient. So they shared the same values and the same views, but then they didn't agree with the processes that were implemented in the network, and they didn't feel that those processes supported them in achieving this objective of, providing the best care to the patient. They felt, staff in the peripheral hospitals felt, that it is much more efficient and beneficial for the patient to refer them outside of the network than to refer them within the network and place them on a long waiting list. Or maybe, outside of the network, there might be more variety in terms of the clinical services available, which might not be so developed at Hospital One. So even though they had a common motivator, their approach was different, especially, and we can see differences between the approach of doctors and nurses. But from doctors, it's because of the inability of referring patients within the network, whereas nurses felt much more positive about this arrangement and expressed more willingness to engage. They also had more opportunities to engage because nurse managers, they moved completely to management, so they distanced themselves from the nursing profession, and that gave them the opportunity, the time to be able to engage in managerial meetings or different kind of collaboration with peers, whereas doctors didn't have the same opportunities.
Yeah, I think you may have just answered Marianne's question in the chat. She asked, did the purpose of creating networks include better patient outcomes? And was that part of your research impact, so to speak, on the so-called end user?
Yeah, that was the idea. Yes, that was the expectation. But no, it didn't really happen. No. to a very for the patients to a very limited extent. And again, there was slightly better outcomes for hospitals that were closer from a geographical perspective to hospital one. They had more opportunities to refer to these hospitals, where hospitals that were much further away, they had no opportunity, so they were working with networks outside. So maybe, let's say, to some extent, yes.
Yeah, so I mean, this is all very complex, of course. You know, we're talking about networks and structures and relationships, and trying to achieve certain outcomes for patients, obviously being one of the main focuses here. So it's certainly not an easy thing. But you know, like, I guess coming back to what we were talking about before, that if they'd done the reform with an understanding of social capital, then perhaps they would have done it quite differently than they ended up doing it. So I guess, like, what do you see as the key takeaways? Like, if the reform was done again, based on your research findings, what do you think would be done differently?
Well, I think one thing that I continue to insist on would be the physical separation between Hospital One and executive management team. And that is a key characteristic of the NAO model in order to make it efficient. So they lost it there from the beginning, where they didn't make it clear that this NAO has to operate from a physically different space or outside of the hospital. So that was one thing, because there is extensive research that found similar findings in terms of the hospital, even in the hospital space. Hospitals that are closer to management, they tend to be prioritized or to have higher benefits in terms of resource allocations than hospitals that are further away, geographically speaking, than to the management team. So that would be one thing. I think that's very important, the separation between, and then much more diversity in terms of forming the executive management team. So to not allow it to be dominated so strongly by prior leaders at Hospital One. So that was really, wasn't really a change there. It was more so in terms of position, the name of the role, and the power that was assigned to that. But it was otherwise there was no change there. They should have operated outside, and perhaps that would have created a more sense of responsibility towards the other hospitals as well, and would allow this NAO to maintain its impartiality across the network. Yeah. I think it was, yeah. They did have an understanding, so they weren't calling it social capital in the reform text, but they did have an understanding, because there is a lot of emphasis on collaboration and what are the benefits of collaboration, and you know, all the reform objectives were developed around or having with the idea of collaboration in mind. So they did have some good views, and also all these new public management reforms and directions proposed by post-new public management, they all emphasize this idea of collaboration, of working together, and the benefits that can be derived from that. So I think they had a good idea, but it had some flaws in terms of the way the reform text was written, where they missed some points that turned out to be very important. So I think that would be one of the things that I would say the most. And then, of course, resources and investment at Hospital One, because they went somehow the other way around. So they created the network, and then they didn't invest in the Hospital One. Hospital One was assigned as a tertiary care unit and was supposed to take on all of these additional patients, but with no investment, it couldn't. So basically, from that point of view, there wasn't much done, because most hospitals continued to work outside using their, you know, channels developed before the formation of the network. So we still notice that particular pattern in their behavior, referral pattern. Yeah, and it's very difficult to break these patterns, especially when you don't have any credible alternative to it. Yeah.
Yeah, and that's why I think Adler and Kwong focused on that ability part as well, that if there isn't the funding there, that it affects the entire system. That, that if you can't do the things, it actually affects the motivation, it affects the opportunities. And so as much as financial resources is not what social capital is about, still, if there is a lack of financial resources, it has that dramatic impacts on the rest of the system.
Well, it does, and there have to be benefits perceived by network members in order to engage in any kind of collaboration, really. But in this particular case, there weren't much benefits, and even interesting, funny enough, when we asked participants what would they identify as the greatest, outcome or benefit of this arrangement, most of them, they said loss of autonomy. So it was perceived, everything was perceived from a negative point of view. So it had negative implications. There were also mentions about losing services because some of the services were centralized in hospital one. So therefore they were removed from these smaller hospitals. And that had significant implications on theater times, because by removing some of the services, some surgeons weren't receiving as much theater time as they had before, so they were very limited. That led to losing their skills in time, inability to train junior doctors. So there was a domino effect there that happened from creating this network, at least in the first 7 years. After that, hopefully it's better.
Yeah, so we've got a question in the chat, but we've got a hand raised as well. Javier, feel free to unmute yourself if you'd like to ask your question. I think you're muted.
Okay. Hello, Mara. Hello, Tristan.
Hi, Javier.
I would like to ask you if you have some in the continuation of the research from 2020 to now, we had the COVID. So
yeah,
I think that the non-collaboration landscape before COVID may have changed to a collaboration mode. And if you have some ideas and some information about what happened with the network in the COVID period, because they were involved in a crisis operational mode. Then what have you found? If you have something to say about it, I think it would be interesting in order to grasp the social capital of this case working in a crisis mode. Thanks.
Yeah, thank you. Thanks for the questions. I the panic social capital. Well, unfortunately, we stopped it. We stopped the research exactly in February, beginning of March 2020 because of COVID, because we still had some meetings planned in the hospital, but we were blocked by COVID, so we had to cancel everything. So I don't really have information from the hospitals on how they dealt with the crisis and to what extent this facilitated the development of more social capital in the network. But this is an idea that we try to kind of follow up on now. It was impossible to go in the hospitals during COVID, but now at this point, this is something that we have in mind to try and approach these hospitals again and look at the impact of COVID and see if that impact, which for sure generated more collaboration within the network because of the crisis, but to see that I would be interested in seeing if they maintained that collaboration, or was it just a one-time thing because we had a crisis and now we went back to doing our own things as we did before. So that would be something to look at. But at the moment, no, we haven't started anything in that space. Thank you.
Great. There's also a question from Marianne. Were there differences in network functioning between public and private hospitals?
Well, there is. I haven't really looked too deep into private hospitals, but private hospitals are mainly focused on profit, where you don't have the same thing in the public sector. In the public sector, usually you have the budget being allocated by, the funding agency, whichever that would be, and then you just have to work within that budget. Usually what happens is the budget is not enough, and we have these deficits at the end of the year. So yeah, there are differences, and I think public sector networks are a little bit more bureaucratic, and that reduces from the efficiency of decision-making process or any operation in any operational sense. The bureaucracy reduces that. So yeah, I think there is, but I cannot tell you exactly in the private sector how it specifically would work, because I haven't worked in that space.
Great. Any final questions? Any final questions? Well, we've got a bit of a pause in our webinar series after this session. We're still running the social capital research and design sessions. The next one is next week. They're run by Dr. Beverly Sloan. If you want to get some help with some research that you're doing, the next webinar is likely to be towards the end of October. We've got a inter-school social capital lessons for school leaders and how to maximize the benefits and networks. So if you want to check the website for that kind of information. Mara, thanks very much for this presentation. We really appreciate all the work you put in and joining us.
Thank you, everybody. Thank you so much for having me over. It was a great pleasure meeting you all, and hopefully we keep in touch and we meet at further future seminars as well.
Great. Thank you.
Thank you so much, everybody.